Well, it's 8:05. Good morning, good day, good evening, wherever you are. I would like to thank the organizers of the International Trauma Tele Grand Rounds, this Sociedad Panamericana of Trauma, University of Miami, Virginia Commonwealth University. My name is David Machado. I'm an assistant professor at the University of Michigan, and welcome to my talk, which I titled, "Don't Play with That Snake, the Essential Role of Trauma and Acute Care Surgeons in the Correct Management of Snake Accidents." So these are my disclosures. I have no financial or commercial interest, and most of the clinical experience, and this is based on my literature research, is on expert opinion. There are no randomized clinical control trials that have been performed to date. I think that would be unethical, like the parachute paradigm. I would appreciate, though, people's experience and expertise in the subject matter. As you can know, Michigan is not well known for its tropical exotic snakes. These are the objectives of our talk today, is to recognize the general mechanisms of injury related to snake accidents and their clinical recognition, to understand the importance of protocolized care and the considerations of early involvement of the trauma and acute care surgeon, and to identify local and regional resources that can improve the clinical outcomes related to snake bite accidents. So, snakes have been related to humans since the beginning of humanity. As you can see, Aesculapius, the god of healing, has his staff with a snake, and that's because, or according to legend, or according to mythology, snakes whispered the secrets of healing. And the gods were so envious that Zeus finally struck Aesculapius down with a thunderbolt. So be careful, all of you, if then all of a sudden we get struck by a thunderbolt, because the way we treat our patients and care, that we resuscitate and are able to overcome the impossible. But as a trauma entity, the incidence and impact is underestimated. In India, over 50,000 people are estimated to die annually. The incidence can vary from 4 to 162 per 100,000 inhabitants, and that mortality can be very, very rare, like in the United States, but in some other places, like in Eastern Nepal, it could be up to 24%, and even more if we consider places like the Amazon jungle, where some census, especially in the Yanomami population, have reported that the mortality in young males is over 50%, and the #1 cause of death has been snake related. So this is an important, I would say, entity that when we are going to design a comprehensive trauma system, it should be also included among its many, many important chapters. So as I said, the death is rare in the United States, and even though people attribute this to the access to antivenoms, it is possible that also the characteristics of the snakes, the species that live in the United States, are not as lethal as they happen in other places of the world. But out of 2,800 species of snakes, there are over 300 that are medically important. Accidents can vary from constrictor type mechanisms like the boa constrictor, pythons in Asia, which usually squeeze and strangle victims, to snake bites with or without venom. The envenomation can also occur without bites. Certain snakes can actually spit venom. And I hope you can learn from my mishaps in this case. And you can see the arrow here. This is where I live in the northern part of the United States. We only have actually only one medically important snake, which is a micro rattlesnake. And a lot of the mistakes that happened was anchored on this thought that the envenomation happened with that snake. So here's my case. DG is a 24-year-old male who presented to an outside hospital after a snake bite in the left lower extremity. Prior medical history is depression and bipolar disorder. These are the vital signs on presentation. His blood pressure is, as you can see, normal, 113/75. However, he's tachycardic, 130. His respiratory is 28, and his GCS is 14, due to his eyes constantly being closed. His airway is intact. He's breathing spontaneously with bilateral breath sounds, 96% in room air. As I said, he's tachycardic and pulses are present in all 4 extremities. His GCS is 14, but he's starting to, there's one noticing thing that he has a lot of salivation, and he has the eye closure is not related to just voluntary eye closure, but ptosis. And there's an apparent bite with 2 prominent puncture wounds in the dorsal aspect of the left foot. Adjunct imaging was performed. A chest x-ray is normal. A foot x-ray, we see no foreign body. And in the picture is our micro rattlesnake that lives in the wetlands of Michigan. So I'll pause here. And at this time, there's no trauma or surgical team involvement. In the box, there is the vitals, as you can see there. So the questions I have for panelists: do you perform a trauma team activation? And do you have a specific protocol in place for these special situations? I'll start with Dr. Untrak.
Yes, so we don't here, we have access to CroFab, and that's the only one available. But the military right next door, they have a clinical guideline protocol throughout the military, all the branches. When especially in the Middle East over here, there are snakes here. When they go out on patrol, they carry 6 vials of CroFab, so that if one of their servicemen gets bitten, if they meet criteria, they can give them the 6 vials as the initial treatment, buy some time to get them back to the Role 2 or Role 3 hospital. And their protocol is by the book. In our hospital here, it depends on the doctor. You know, I think part of the problem is most ER doctors we see very few of these throughout the country, unless you're in an area in Arizona, someplace where they have, in the desert Southwest, where they have abundant snakes, and they see lots of them. You know, it's sort of, you know, the experience isn't there. So some of them say, well, if they come in, you see the tooth marks, go ahead and give the antivenom. But in the military, no, they have to have signs of envenomation. And I think that's the role for the trauma surgeon. I don't think you need a team. You have to be prepared to undertake critical care if the patient has an anaphylactic reaction in response to an antivenom, or if this sounds like this patient may have been bitten by a coral. I don't know if you have coral snakes there, but he seems to have a neurotoxin, may need to be intubated and have ventilatory support. And in that case, the CroFab would not really neutralize that toxin. But if you really don't know if there are signs of envenomation, I think, depending on how severe it is over the course of observation, then you go ahead and give the CroFab, and then you watch them carefully for signs of bleeding. And but that's the protocol that the military uses. And if I were to see something like that here, that's what I would do. I was in Sri Lanka 25 years ago, and at that time, patients would, you know, they have this happen all the time. They just kill the snake, and they can spend all day walking to the hospital, show the doctor what the snake is, and all they do is they give. At the time, they had polyvalent anti-snake venom, which we don't have in the States because it's crude antibodies made from horses and a lot of reactions to it. And we would just observe them most of the time when they sat in the ICU. The next day they were fine, except for some local effects where the bites were, and then that's typical wound debridement, usually a skin graft on the dorsum of the foot or whatever is needed to get the wound closed. But I personally haven't seen any really bad envenomation reactions, but I was faced with one up here in Kirkuk, going to be going on 10 years, a 34-year-old man. He had 2 clean puncture wounds. They flew him in by helicopter, 2 dry bites. We gave him, as 2012, the CroFab, and then in retrospect, we didn't need to because it looked like a dry, a non-envenomous bite. But that's why it's important to see these, and you're giving this talk I think is very important for us to keep reviewing this and to have a very simple plan.
That's super excellent.
In my hospital, trauma team will not get activated from a snake bite unless there's specific issues like compartment syndrome or extensive necrosis of the skin. And we have a specific protocol for snake bite in my hospital. Usually the patients will be taken care by emergency medicine and the internist. And two most common snakes that bite people in Bangkok are green pit viper, which has hematotoxin, and king cobra, which has neurotoxin. And for this particular patient, it seems like he's having problem with respiration from neurotoxin. So he should be urgently intubated, and the antidote should be considered according to the prevalence of the snake in your region. Thank you.
Dr. Hoyman, sir, your comments.
Well, I admit I have no experience with this. We live in Boston, so there are not too many snakes that I am aware of in this area. Even when I was in North Carolina, I didn't see this. This seems, the little that you presented with the symptoms seems like anticholinesterase effect. So I will treat it like that, like a organ phosphorate, but it wouldn't be me. It would be consult the poison center, and it will be managed by the emergency department, and go from there. If he has tissue necrosis or have other things, we might be consulted, but we were not. We get consulted for bites, like rat bites or dog bites, but really, usually we don't do too much for those, and they might consult us for something like this, but honestly, I've never been consulted, so I don't feel qualified to answer this question. Sorry.
I see Dr. Untrak has raised his hand.
Yeah, I was a little surprised at something that Dr. Hockman said, that you don't have any snakes in Boston. I seem to recall it, not even in the surgery department. I seem to recall you saying there was, the occasional snake slithers through.
They're confined to the Harvard hospitals, I would say.
Yeah. Okay. All right.
Okay.
Well,
Okay. We will continue. So
how about Dr. Alex? Dr. Alex.
Oh, Alex, I didn't see you. How are you, sir?
It's okay. Good morning. Thank you. I train in Miami. I haven't really encountered snake bites. I did take care of some, shark bites, but not snakes. Just kind of reading about this a little bit, honestly, to be sort of prepared for your talk. I think it's important to really identify what the snake is, and just reach out to whoever would make the serum, particular serum for the snake. And again, there's going to have to be a decision based on, what type of reactions are, because of Dr. Ontrak was saying there are severe allergic reaction when you give the antibodies that would, the anaphylactic reaction up to like 50% of cases. We don't have a protocol for snake bites at Jefferson University, where I'm at. And with regards to this particular case, I would be concerned about, systemic envenomation with the symptoms that he has. Maybe he got poisoned with some chemicals and he was bitten by a snake that is not poisonous, but I would be concerned about his airway. So I may reach out to anesthesia, but not necessarily a trauma activation here. And I would definitely send labs, including coagulation profile, just to kind of get an idea of what kind of systemic derangements occurred from the venom. That's all I have. Thanks.
Thank you all. So we'll continue. So patients' IV access obtained, an initial bolus of 2,000 mLs of crystal air given. And because of the excruciating pain, and as all of you pointed out, the neurologic symptoms that point towards a systemic envenomation, patient gets intubated with a rapid sequence intubation, receives immediately 6 vials of Profab, similar to what Dr. Umtrak has said, as empiric treatment to buy you some time by slow infusion. And given that this is our only endemic snake, is rattlesnake, of the viper family, CroFab should be adequate treatment for something like this. No local wound treatment. Here are his initial labs. His hemoglobin is 14. His BUN creatinine are right now in normal range. Glucose is normal, and his initial coagulation profile is normal. And then his first gas, it shows a slight alkalosis due to probably his tachypnea, and then his oxygenation doesn't seem to be a problem. Vent settings are standard. So at 6 hours though, his urine output continues to drop. And despite of additional boluses, IV fluid, he receives a total of 6 liters in the first 6 hours. He's starting to show like signs of hemodynamic collapse with requiring vasopressors. 4 more vials of CroFab are given, and in what is impressed by the outside hospital physicians is that the large blister has evolved into a sloughing skin with extensive necrosis around the area of snake bite. And the patient's starting to become more and more hypotensive and hypoxic. So becomes finally anuric at time 24. After 10 liters of fluid have been given at over 24. And the first call to poison control has happened at 24 hours. And then persister, this is an interesting thing. The patient is an exotic pet collector. He collects rattlesnakes, vipers, botrops, which are the fer-de-lance, and then cobras. And I think the lizards are actually of the venomous kind, like monitors and so forth. So you can see that his white count shows like an inflammatory response. He's now becoming anemic, or perhaps because of dilution. He's starting to show organ failures such as renal, and now hematologic symptoms as well, and with elevated CPK. And then his gas is now acidotic with hypoxia, and in spite of now adjustments on the ventilator, so you're starting to show also similar symptoms of an ARDS type phenomenon. So given the progression of these systemic effects, would you advocate to sacrifice the limb over life? And then could this be a misidentification of the snake? We did the wrong antivenom, or could this be serum sickness? And I think Dr. Umtrek already touched a little bit about this. I'll start with Dr. Suparak.
In this patient, I think we should get consulted by now. And for the leg, I think he may have like extensive necrosis of the skin and muscle underneath. Maybe he will also have necrotizing infection, and he's suffering from rhabdomyolysis too and compartment syndrome. So we should take him to the operating room and perform a fasciotomy of the left leg and try to debride the dead skin and muscle. I don't think we have to amputate the limb at this time, but that should be considered if the patient doesn't get better after the surgery. And of course, he should be moved to the ICU for organ failure support. About the wrong antivenom or serum sickness, I'm not quite sure about this, but I will give him empiric antibiotics, and I will consult the snake specialist to help me figure the antivenom for him. Thank you.
Dr. Hoytland, your comments, sir.
So he's an exotic pet collector, and he doesn't tell you. That I always say, never underestimate people's stupidity, and this reinforce this idea. The little I know about is snake venom. There are some of them that produce tissue necrosis that is local, and others that cause generalized because it gets distributed by blood and it has hemolysis or kidney failure, or you have neurotoxins. If the local tissue destruction is the source of all of this, which I don't think so, you will have probably other symptoms by now. First of all, the CPK will be much higher. you will see hematuria, which is myoglobinuria, or even if you have hemolysis, you will see the urine turning red as an explanation for his kidney failure. So I don't think the amputation will help. I agree with Dr. Supa that if a local exploration showed tissue necrosis, yes, resect the tissue that is necrotic, but I don't think an amputation will help. This appears to be the systemic effects of the venom. And I will be, again, consulting I would suggest to consult the poison control center to see what recommendations they have and see if we can find something more specific for the type of weird pets that this patient might have. Talking about as a, I don't think this guy has it, but something to think about. Maybe if I know that the Komodo dragon killed his prey by biting, and it has so many anaerobes that usually the prey get infected with Clostridium, and they get Clostridium necrosis and die, and that's the way that they don't have a proper venom. But maybe one of those weird lizards that he have, something like that, have some similar mechanism. So he might have a necrotizing soft tissue infection from common organisms. So that's something to also consider, but that's all I can think with my limited knowledge. I will ask somebody who knows more than me if I have this problem. I wouldn't be making the final decisions. So I'm not too much help here, sorry.
Dr. Alex, your comments, sir.
I don't think I would amputate the leg at this time, but I would definitely agree with everybody. Go to the operating room, debride the non-viable tissue. Also keep in mind the possibility of superinfection. Make sure using broad spectrum antibiotics, send cultures, and then see how the muscle compartments look like, and perform fasciotomy based on how things look like in the operating room. And give him a tetanus shot if he didn't get one, and maybe have somebody go to his house and carefully see what type of other poisonous animals he has there, and call the infection and the, I guess, the proper channels to make sure we get the antivenom that will probably save his life.
Dr. Untrak, your comments, sir.
Yes, I forgot to ask, how much time was it between the bite and when he came to your hospital, and how much time lasted between the bite and the initial dose of Crofab?
The bite.
You might have mentioned it, but I forget.
Sure. So the time of administration of the first dose of Crofab was 2 hours after the initial bite.
Yeah. So about the time, I don't know if that would be considered too late or whatever, but, and I agree with everyone, at this point, the cat's out of the bag. It's a systemic problem of envenomation, and that is either, and he seems like he got a lot of Crofab, so it should start to neutralize if the Crofab is active against his type of venom, and you initially thought that it should be, although as you pointed out, the bite might have come from a different kind of snake. And although these days, people have cell phones, and unless somebody's alone and they're just not thinking, just take a picture of the snake and bring that in. But that's probably the best thing, rather than trying to kill it and capture it and carry it in. But I agree. I wouldn't amputate because it's too late. He'll just, he may recover because of the treatment, and then the amputation would have been unnecessary. And the other thing is, I would be concerned about slowing things up too much by going to the OR to debride that local area. And usually patients that get bit by snakes, the bite tends to be subcutaneous, not intramuscular. So the recommendation, I reviewed this earlier today, is that unless there are clear signs of a compartment syndrome, and this is an exception to the rule that if you think you do it, it's a different kind of trauma, but unless there's clear signs of compartment syndrome, you should measure the intracompartment pressure. and don't do a compartment fasciotomy unless the pressure is elevated, because if the compartment's not already infected or affected by venom, you can introduce the venom. It can cause minor necrosis, and then you have a bigger problem. But it's okay to locally debride the wound. And if that seems advisable, if he has a lot of swelling and crepitus, I would try to do that at the bedside in the ICU or the ER with ketamine or whatever kind of limited anesthesia. And in the meantime, I agree with the antibiotics, and then possibly a local exploration, limited one, and then treat him with the good critical care, including treatment for serum sickness and anaphylaxis. Do everything. It sounds like you're doing that. He's on pressors, and I don't know if he got H2 blockers. You know, the full expert treatment. What I would call the intensivist, and for that to be sure that he's getting everything for prophylaxis, and he may need either the PA catheter to figure this out, or a good ultrasonic examination. The rapid ultrasonic exam and shock can give you the same information quickly if you're skilled at doing it. And but I would focus on that. My understanding is the only antivenom we have in the United States is Crofab. There's really nothing else to give. There was a limited single endowment of the antivenom for coral snakes, which I don't think live in Michigan, but maybe he collects them. But even so, that if that's the case, and there are some vials available, limited vials, you may have access to that. So that's the only issue there. The only thing you can do differently. So aggressive treatment for serum sickness and anaphylaxis, and ask the poison center, should we try to procure a dose of the antivenom for coral snake, and then, but don't, if you move to the OR, to do a small procedure, it's going to delay the treatment for, 40 minutes or so, or however long it takes you to get back. So I would try to limit the local procedure to the ICU, just to drain any fluid. You can send gram stains and culture, whatever. And I also agree with the antibiotics. Pretty much everything other than doing the fasciotomy.
Can I ask a question?
Dr. Hoyman, I saw Dr. Proctor lift a hand, and then I'll follow with you, sir. I'll follow up with you. Dr. Proctor, your comments, sir.
Thank you for presenting this case. I'm a scientist, not a surgeon, so I'm just asking a basic question. First of all, just from watching National Geographic and some of the zoo shows, many of these people that are the exotic or venomous pet collectors have been bitten multiple times and have some very strange immune reactions when they get bitten one more time. So the question is, has he ever been bitten before? And the second question I have is, my understanding is there's basically two fundamental types of antivenom. The first is hemolytic and proteolytic, and they put a bunch of different kinds of proteins that they get from the different kinds of snakes to deal with that. The other type is neurotoxic. So if the Crofab doesn't work, how do you treat the neurotoxic effects of this envenomation? So in summary, two questions. Has this guy ever been bitten before? And if the Crofab's not working, why don't you switch to the other kind?
I'll answer those after I allow Dr. Hoyman to speak. Dr. Hoyman, sir.
Listen, we are all kind of, obviously, none of us has extensive experience with this, so we are all throwing crazy ideas. But this patient has systemic symptoms. The majority of the venoms that the mechanism is usually a protein. So I was wondering if there is a way, kind of like a desperate throwing, is to do probably dialysis will not filter, but maybe plasmapheresis to remove the protein from the circulation. I don't know if this have any scientific, but we're kind of like throwing crazy ideas, because obviously this patient, whatever he got is not working, and most likely he's not going to receive the specific venom. One thing that I do know about snakes, this guy might have been doing this, I don't know, if the snake bite an animal, whatever, they have a limited amount of venom. So when they might bite you, maybe they don't have enough venom, so that happened. And many of the people who play with the snakes and circus and things like that, they milk the snakes before playing with the snakes. So even if they get bitten, they don't get a significant amount of venom. So even if he was bitten before, he might not have developed antibodies against the specific venom, so it might not work. Having said that, I doubt very much that he is doing this routinely to build enough antibodies for those specific snakes. Thank you.
Yeah, I also want to thank the people in the chat. They've referred to the National Trauma Data System Trauma Registry for inclusion and exclusion standards, and the majority of these accidents just require a consultation, but not necessarily trauma activation. Thank you for clarifying that. Dr. Proctor, that information would have been useful. However, he got intubated almost upon admission to the outside hospital. So we do not know exactly if he has that homeopathic type of medicine approach for developing resistance to the snake venom. However, with that being said, if you look at literature, it's highly controversial, the development of antibodies and resistance to different venoms because some species actually bury their venom from the age of the snake. So if you're getting by a juvenile, this not necessarily means that you're going to have protection from an adult. So even if you have it may be a mini dose from a juvenile snake, it may not necessarily give you protection later on in your life. So the literature does consider that hypothesis. However, I think that the people that do not survive do not present their data. So therefore, we don't know if it's effective or not. So the animal control went to this person's house and found that he had a missing monocled thigh cobra, and apparently this was the offending animal. And then finally was confirmed by its capture, and it was ID'd by a zoologist here at Michigan. So he was transferred to our hospital, and the reason I got involved was that our team actually specializes in providing ECMO support. So this patient, given the systemic envenomation and the ARDS and the collapse, we were about to, the request for transfer was for a higher level of care and ECMO, and then also a second opinion of the limb. And here's actually our initial picture of the area of involvement. And what is telling is the rest of the leg, the leg and the thigh do not appear to have much involvement. And we actually measured the compartment pressures in those areas, and they were less than 15. So they did not have any symptoms or actually objective data of compartment syndrome. So we did exactly what Dr. Untrek pointed out. We did a local debridement at bedside of the wound. And then I asked the questions, okay, well, how the heck I'm gonna get Thai cobra antivenom to Michigan? So, and here's a little a picture of a monocled Thai cobra. And the question is, and I think Dr. Untrek has mentioned this, do we have access to this type of venom or antivenom? Do we have a bank? And is it too late to provide antivenom? And now we're at hour 30 of envenomation. I'll start again with Dr. Untrek.
Yes, so correct me if I'm wrong. I've read that that the CroFab should cover the vipers and the cobras and everything except the coral snakes, for which that's the one where in the States, Pfizer made one time an endowment of the antivenom against the coral snake, which causes has a neurotoxin, and it's not being produced anymore. But there's still, if you need it, there are some scattered. So, but I don't know for that particular, and this I would ask the experts if the Poison Center knows. But if he had a lot of crowfab, should that cover this snake's venom? And my understanding is it should. And the other option is, that the ones in Sri Lanka, they have cobras and vipers. They were giving them the whole polyvalent anti-snake venom that would cover both, so that they don't even know what the kind of snake. But those are the whole antibodies that have a lot of side effects rather than the FAB fragment preparations. Although if the patient's not doing well, if he continues to get worse and it's possible to use it, then I would try to use it. And these days, I think they can probably get, if it had to come from India or Sri Lanka, they could probably ship a dose and FedEx overnight, however they would do it. But whether that's practical or, for one patient, I don't know what the options are. But I would, since the kind of snake that he was bitten with, I would find out. And I think you've done that.
Yeah.
What the
Dr.
options
Proctor,
are for.
Sure. I'll let Dr. Proctor, he has raised his hand.
Yeah, I
Oh,
just
Dr.
saw
Proctor.
by coincidence that Miami-Dade County has the largest anti-venom unit in the country, and they send samples all over the place. So you could have called us, it looks like.
I'll let the other panelists, because for full disclosure, I did not provide the slides to the panelists, but they're answering all these questions already. Dr. Suparak.
If this has happened in my country, in my hospital, it wouldn't be any problem, because the antidote is across the street from my hospital in the Red Cross Society. But it happened in your city, and I think it should be a problem. Usually, king cobra bite will cause paralysis of a respiratory muscle. And if that's the only issue and you don't have antivenom, you can just wait it out until the venom fades away by itself, and the patient will be able to move and to breathe normally after the waiting period. But this patient seems to have multi-organ involvement from cytotoxicity of the other venom, and I think he needs antivenom. So at this time, you should support the organ failure and try to get antivenom from either India or from my country. Thank you.
Dr. Hoyman, sir.
When I saw the type of snake, I would call Dr. Supa and ask him for help, because he's probably the only one who have seen this, I imagine. Why somebody will keep this as a pet, I don't know. I have this is a coaster that I found a few years back, and I have it in my office. I don't know if you guys can read it.
Yes, sir.
Yeah.
Genius has its limits.
This patient of yours really kind of like this is beyond me why somebody would do something like this, but
Thank you. Dr. Alex, your comment, sir.
Yeah, I think from reading the, actually the trauma book, earlier for this, I think the supplies for the coral snake, and the venom, really it's limited, and it has not been, I guess, produced as much as it has been up to 2003, and then kind of expires in 5 years. But it is available if you need it, I guess. You just need to know whom to call. So I'll call Miami if I run into this. With regards to giving it 30 hours after, I think I would. I would definitely give it and continue supporting measures, including ECMO. Thank you.
Yeah, so thank you. The CROFAB stands for Crotalane family, which is the part of the viper family. It only covers the rattlesnakes and some of the vipers, but the cobras and the coral snakes belong to the elapid family, which is the one that provides neurotoxin. Also in that family are the sea snakes and the Sri Lanka crates, banded crates that are also very medically important. As the panelists have pointed out, two major groups of venoms. One are proteolytic, and then the other are neurotoxic. So we need the appropriate antivenom, which was thanks to our friends at Miami-Dade Poison Control. They do have a public antivenom bank, and this is public service. You call them and they were able to ship us via courier the appropriate antivenom, and we were able to give it. And this is actually thanks to our friends from the Thai Red Cross, as Dr. Suprek has mentioned. And we did as I said, the debridement for source control, serial assessments for the limb and the abdomen. And then considering that there could have been a side effect reaction from prior antivenom administration, we started steroids and all the anaphylactic anti-anaphylactic measures. This is actually the initial chest X-ray. You can see bilateral infiltrates similar to ARDS. And then there was no gas formation, so the suspicion of a necrotizing soft tissue infection was also very low. He did end up growing Morganella morgagni as the primary organism, but in fear of Clostridia, we did have him with adequate anaerobic coverage. And you can see here is progression of vital signs that he went from a PF ratios of 60 in the outside hospital to really quite quickly improvement once we gave the appropriate antivenom. And to my surprise, even at 30 some hours after the envenomation, the antivenom works. And this, I think, makes sense because not necessarily the snake bites and then immediately the animal dies. Sometimes they just bites and keeps it like alive for a while and allows the rest of the digestive process from the rest of the proteins that are in the antivenom to work. But fortunately, the patient got extubated, avoided renal dialysis, and I think this all happened due to, as I said, the appropriate antivenom. We've then placed Integra dressing, followed by a skin graft to the delay fashion, and finally got discharged to rehab after 26 days of hospitalization. Patient still has moderate neurologic deficits such as a neuropathy and perhaps due to the neurodestruction from the antivenom, but we were able to save the situation thanks to the appropriate antivenom. So I just want to do final comments here, and we do have a protocol. Actually, realized that after all this happened, we did have a protocol in our hospital. And as Dr. Untrak says, the military has a protocol that they follow by the book. I should have just followed the protocol by the book. And I think the key here is the identification of the snake. And this could be where you may require a non-medical expert, such as a zoologist. And in our case, we use the help from the Museum of Zoology here at Michigan to keep the extremity in neutral position. And I think we can also have a complete discussion of pre-hospital care about all the things that work and do not work, but it's out of the scope of this talk today. And then use some sort of assessment tool to know if this is a dry bite versus a envenomation bite, so that then it can guide you with the administration of the different antidotes for the snake envenomation. So in our case, we use something called the snake bite severity score, and I have a slide that shows it later. But then in our protocol says consult both plastics and trauma. And if the patient has local symptoms, the primary is plastics. If the patient has systemic symptoms, then the primary is trauma. And then the laboratory, as Dr. Alex has pointed out, to see the different side effects or laboratory side effects given from the venom. And also, if you cannot recognize the snake, sometimes this information could be useful for poison control. And then based on the venom's profile and the systemic effects that are happening, the poison control can provide you then idea of what the appropriate antidote should be. As we've mentioned in this talk, that there's a balance between the two type of venoms, or the proteolytic group and then the neurologic group. And Dr. Supa has pointed out that if you're in the situation where you don't have antivenom, especially in the neurologic envenomation, just providing supportive care should be sufficient to and wait till the effects of the venom can disappear. And then this is the snake severity score, which uses similar to like trauma, injury severity score, different systems, and you point system that allows you then to score the injury severity. But I have a different score, scale that I'll show you in a moment. But this protocolized care has proven to decrease the excessive use of antidotes, and the antidotes can actually be given up to 48 hours after the accident and they'll still be effective. And this is actually the scale that we use at Michigan, which I think provides you like a color system, easy to follow, where you look at local versus systemic versus coagulopathic. And I think coagulopathic could be by itself a severity index. And then of course, the higher the scoring and the more severe the symptoms, the more vials you administer. But in our state, we only have one venomous snake, and by default we would use the CroFab. But then in something like this, we will definitely ask for help from source control, from poison control. A well-timed intervention from the trauma surgeon is important because, as mentioned here, some of these venoms can cause compartment syndrome, not necessarily at the site of the envenomation, but it could be actually distal. So any area of suspicion should be measured, and if there is indeed compartment, then actually mini physiotomy should be done, because as Dr. Umtrek said, the extensive compartment fasciotomy can disperse the venom at a quicker rate. And then here on the right side of the slide are some of the other of the long-term consequences of the venom, such as mummification of limbs, neuropathy, and atrophy of the limbs. So the opportune intervention of the acute care trauma surgeon can avoid some of these sequelae. And it's important to know that the compartment not necessarily is related to local destruction, but as I said, you may have to monitor for other things like abdominal compartment syndrome, because the systemic absorption of the venom can cause things distal to the site of the bite. Okay, and then be familiar with the endemic snakes of your area and their venoms. Ask for help from experts. In terms of antibiotic prophylaxis, is very controversial, but as mentioned in this today's talk, the snakes have anaerobic organisms that can cause rapid necrotizing soft tissue infection. So you should cover, at least in our policy and in our institution, these snake bites do get antibiotic coverage with especially with penicillin type antibiotics for anaerobic infection. And then I would say that the analogy of what a snake bite is, especially in severe envenomation, is almost like a polysystems trauma, but it's happening in slow motion. And given the research now, I'm called at my institution the snake doctor. I don't know if that's a compliment or is it a insult, but I take it as a compliment. Okay. And then this is the webpage for Miami-Dade poison control. I have sent Valeria actually the list of antivenoms that are available, and it's quite extensive. And I have to say that I have to thank people from Brazil, Mexico, Costa Rica, because a lot of the antivenoms that are in that bank are actually from these countries, and of course from Thailand, for this particular case who helped my patient. But this is a public service, and the phone number is there, and I have put in the list of in a PDF file for distribution by Valeria for those that are interested. But it is important to know that there are limitations of this talk today. We've talked about hospital care, but I think most importantly, pre-hospital care and appropriate first aid is as important as hospital care. And then to transport this patient to definite care as soon as possible. And then finally, injury prevention. And I think as a comprehensive trauma system, we have to consider, even though this is a rare event, it is dramatic and fatal. And as I mentioned earlier in this talk, that happens in rural areas, and then happen at High Cobra in Michigan, to me, is almost being in the middle of the jungle where I didn't have the adequate resources to treat this patient until finally the appropriate antivenom arrived. So final remarks, Dr. Untrak.
Yeah, so just if you can clarify, so you called both Miami and Bangkok, and then got the antivenom only from Bangkok, is that right? You called them at 30 hours, and how long, if that's so, how long did it take for the antivenom to arrive?
Well, I called only Miami. Miami has the appropriate antivenoms. They sent us via courier to Michigan. So they have a stock of antivenom available.
For that, and it arrived what, overnight or 10 hours? Yes. Or what?
Yeah, it arrived overnight within like I think hour 36 from the accident.
Wow, that's great. And then the anti-venom, is it just you know, a collection of antibodies from an immunized animal, or is it FAB fragments? Is it FDA approved or just under emergency use authorization? What's the you know, is it or is it only available under emergency circumstances directly from Miami?
Yeah, I did have to call the FDA to provide an emergency authorization. So it is it is a product from, I think, Ovine and true antibodies. So polyvalent antibodies. Yeah, not like Crofab, which is FAB fragments. So that is why we also had the patient on steroids, and we're monitoring also for effects of hypersensitivity and anaphylaxis. Yes.
Okay. Well, one last point. I mean, you know, it seems bizarre that somebody would do this, but you mentioned that that this young man has a severe psychiatric disorder, which explains it. So, you know, it seems like a crazy thing to do, but you know, it can't really be too hard on the patient in this case. But anyway, it's but well done. I mean, there were no mishaps. I think beautifully handled for an unusual case. You know, just a superb result.
Dr. Supa, your comment, sir.
Thank you very much, Dr. Machado, for presenting this case to the residents, and I learned a lot about this case. We searched the paper about cobra bite in Thailand, and usually it causes mainly neurotoxicity, and we haven't seen such bad organ failure like this patient. So this is very interesting. Thank you very much.
Dr. Hoigman, your comments, sir.
My comments, I learned a lot. I didn't know any of this before. I learned a lot. This was really very good. I would know what to do. I'm thinking, yes, there are not snakes in Boston, but naturally, but you might have someone doing something like this, and we might see one case like this tomorrow. So it's good to know where to do, who to call, and what to do meanwhile. So this was an excellent presentation. Thank you very much.
Dr. Proctor, your comments, sir.
Thank God for Miami, huh?
Dr. Alex, your comments,
Two
sir.
of the former fellows, Supa and Alex, both were here when I was here.
Very good to Dr. Proctor.
Excellent,
Good to
excellent.
Good to see you, Dr. Proctor. Again, thank you for presenting this case. A very nice presentation. I learned a lot. I did a little bit of reading, but this is actually, you know, what you need to do, whom you need to call, and how to get the right treatment for the patient. Thank you for presenting it. One thing I want to say, when I alluded to like have somebody go home and see what else this guy has in the house, to kind of help figuring out what the, you know, what bit him, that's kind of also to you know, maybe there should be some restriction to like what kind of, you know, animals and snakes you keep in your house, because in the event they escape, then, you know, you have a larger population at risk. So are there any measures with regards to that you can comment on, or in process for this particular case that you can tell us? And thanks again for a nice presentation, and appreciate it. Learn a lot.
Yeah, the regulation of exotic animals in Michigan is done by the local ordinances of cities and municipalities. And I think the issue is sometimes they cannot anticipate every single type of eventuality. But I bet that this community, after having this mishap, has probably come up with a regulation about exotic animals. But there are places here in Michigan that people still have lions and tigers and other exotic pets, and they unfortunately, once in a while, there will be an accident and that makes the news like this. Dr. Untrak, you have your hand raised.
Yes, a good point that Dr. Alex raised. Isn't there something in all states is a child and youth protective services or some equivalent like that? If you see something that suggests abuse or neglect of a child, of a minor, you know, the state comes in and they do the appropriate evaluation to protect that individual. And I think there's something equivalent for adults who are impaired. And I think sounds like it's that kind of a case. And I don't know if you pursued something, if your social workers suggested pursuing that avenue to be sure that this young man, because of this behavior and what happened, nearly died, that he not be allowed to keep these reptiles.
Yeah, thank you, and you're absolutely on point. Unfortunately, by confidentiality, I cannot disclose any of the other issues related to this case. But thank you for bringing those up. And it should be noted that it's not normal to be playing with snakes. So please, please, please don't play with snakes.
Well, I think that this is interesting that you cannot disclose this to the authorities, but I think you should consult with your legal department, because that's kind of like a national precedence of common law, where the obligation to inform if someone is a danger to himself or others. Mm-hmm. That was the famous Tarasov case in California, that the court ruled, and that if you suspect that the patient is dangerous to himself or others, you can confine the patient to the hospital, but also you can warn the authorities that this patient. So maybe this qualify with that saying, because this is a danger to his neighbors. Is one of the snakes escapes can kill someone, and yeah, I don't know. We are not doing too well in the common sense department in this country nowadays with the vaccines and all those other things. So I don't know. Good luck.
Thank you. Yeah, no, Michigan has only a 55 to 60% vaccine coverage at this moment, despite the advantages of being able to have access to the vaccine. Dr. Untrak, you have your hand raised.
Yeah, and to follow up on that point, you know, we're all doctors, mostly surgeons and a PhD scientist, and also we don't know, and we're discussing a patient whose identity we don't know. So there's no HIPAA violation unless there's a separate confidentiality rule that you have in Michigan or federal. I don't know of any federal rule, but without linking the personal identifying information with everything else, like, we know that this patient has a psychiatric history, and that would be forbidden to disclose if it were linked to the identity of the patient. But if that's what you're told by your hospital experts, then I won't quibble with it. But it sounds, I agree with Dr. Hockman. It sounds a little strange. But anyway.
A few years ago, 20 years ago, when I was in Massachusetts, my first thing in Massachusetts, I have a patient who was admitted to the hospital after the third serious car crash while intoxicated. She had, at the time, were paper charts, a chart this big, with multiple admissions with DT and detox, whatever, and she still has a driver's license. And I wanted to report her to the DPH, and I was told by the hospital lawyers if I would do that, I could lose my license because I would violate the patient's privacy. Nowadays, we can. There are mechanisms here, even in Massachusetts, to report those patients to the Department of Public Transportation or but there are rules in many places where you cannot disclose this type of things that prevent you. But I don't know. I think that, and sometimes doctors don't want to go to the legal trouble to have to go to court to defend their decision. But that's the reason you have to consult with a lawyer, see if this qualified and they're the same principle of putting other people's life at risk. But it's problematic in some states.
I totally agree, and our responsibility is for society as well to protect others. So I totally agree. Well, it's 9:06. I want to thank all the panelists for participating, and these are our references as well. This is being recorded, and then from on behalf of the people at University of Michigan, best wishes for all in this holiday season. Stay safe, and I hope we can see you in the near future. Thank you.
Thank you. Would you mind putting the slide with the references one more time so I take a picture of it?
Oh, yes.
Okay. And the next one. Thank you. Thank you so much. Happy holidays and Merry Christmas to everybody.